We are here at Duke Spine Institute, Surgery Center Vieira. Our patient has cervical disc disease, and cervical disc disease is a general term. It implies a problem with the discs or cushions between the bones in the neck, cervical being the neck part of the spine. And she has pain in the neck going into her arm with symptoms of radiculopathy in her left arm, and we're going to be approaching the treatment of these problematic discs on the right side, or opposite of the worst arm symptoms. Her right arm has no problems, her left arm is really the issue. So she had the option of doing fusion, anterior cervical discectomy and fusion, which would be a very invasive surgery. The incision would be about that long, at least. Big long incision, lots of scar tissue, metal plates, screws in the spine, cages, and loss of movement permanently, and then possibility of adjacent segment disease or wearing down the discs above and below the fusion. She didn't want that. She traveled here to Florida to have the Duke laser disc repair. This is a state-of-the-art surgery. It will replace spinal fusions in the future. The problem is not many surgeons know how to do it, and they don't have the equipment or training to do it. So right now there's only a few places in the world you can get anterior cervical endoscopic surgery done. Duke Spine Institute in Florida is one of those locations. So she traveled, as many patients do, to have her surgery. Now she's got 3 discs that are problematic: C4-5, C5-6, C6-7. So without further ado, we're going to get started. Her neck is nice and supple. She's completely relaxed. We have our phenomenal anesthesiologist, Dr. Santiago, here, who's done an immense job here of positioning her perfectly to make my job less stressful and easier and safer. So I'm palpating the spine, and I'm going to try to place the needle at the middle disc. Shot. And that would be 5-6. So 2, 3, 4, 5, 6. We're just about 5-6. And get ready to do an AP when I tell you, but not yet. And shot. Let's go AP quickly. This is a quick AP. You will have to radiate my hand. Shot. Again, that looks good. Go back to a lateral. I'm looking for the tip of the needle. It needs to be in the midline of the spine. Of course, you could see all my bones in my hand, which sucks for me, but we get radiated all the time in spine surgery. Obviously, we do our best to minimize radiation exposure, but it's impossible to avoid it completely. Shot. Shot. That looks pretty good. Give me an AP quickly. You're doing a good job there. Try not to bang the table as you move. I can't get rid of this yet. Shot. Quickly. All right, and you're pulsing, right? Lateral, lateral, lateral. You're doing good. Get me to a lateral view. So at this point, the needle is right at the front of her spine, what's called the anterior longitudinal ligament. And we're right in the midline. I'm very happy about that. So, shot. Okay. And now that I've advanced a little bit, shot, I can go ahead and do another shot with the coker. Let's go AP. AP. Now I can get my bones out of there and soft tissues. So radiation is still necessary in spine surgery. 2, 3, 4, 5, 6. I've got 5, 6. It's perfectly in the middle. It's beautiful. Go back to a lateral view. And radiation is the x-ray machine I'm talking about that you're seeing those pictures. There's really no other way to navigate with the spine, because the spine is made of bones, and that's how we navigate in this day and age, and we've been doing it for many years, using x-ray radiation to navigate. Shot. So I'm going to try to advance this needle into the disc space far enough to do my discogram. Shot. And that should be pretty good right there. We're going to do a discogram. We're a little overexposed, guys. Let's see if we can make an improvement there. So we're in the 5-6 disc. So count from number 2, 2, 3, 4, 5, 6. Everybody in agreement? So we got to do the one above and the one below. I'm going to do a discogram first. Shot. She's got pretty collapsed discs. She's got some disc material that is shot extruded out, and it's over in the let's see if I can advance a little bit more. Hold on. In her foramen, neuroforamen. So my goal is to get rid of that material. Shot. All right. And you're pulsing, you said? All right. So far so good. I just want to get back a little bit further. Shot. And this disc is pretty badly damaged. But despite the fact the disc is damaged, it doesn't need to be fused to get rid of her symptoms. The Duke laser disc repair procedure you're watching is endoscopic. It's minimally invasive. Shot. Our patient is still awake and still under, I'm sorry, is still asleep. I apologize. I meant to say asleep. She's under general, yeah, she's under general anesthesia. Shot. We have 2 cervical cases today, right? Yeah. So she's under general anesthesia. I just can't get a lot of dye out because her disc is so scarred up from chronic inflammation because of the damage that's been done to it for years and years and years. This is not a new injury to the disc. It's actually an older injury. Shot. Now, some people will have an old injury to their disc but have no symptoms. And then they get an acute injury, a more recent injury. Shot. And then they become symptomatic as a result of that. All right, so I didn't get a lot of dye in there, but you can see there's a little bit in the back, not much. And now we're still relaxed, correct? Correct. So we're going to go ahead and shot. We're going to go ahead and take our needle out and make our incision. Take. Okay, a little bit of venous bleeding, no big deal. We have a little skin numbing medicine. Will also help with a little bit of bleeding.
No,
Huh?
we're good.
No, we're fine.
It's only one time and that's it.
So I raised the little wheel with my local. Everything looks good. Get a shot. Guide wire is still where it needs to be. Now I'm going to make a 4mm skin incision. I'm going to try to do all 3 discs. Can you help me out, Luis?
Yes, sir.
Just go ahead and retract the skin. Yeah, put your fingers there and retract it towards you. There you go. Perfect. All right. Let's just wait a minute. I'll put a little pressure. Let go. So we have a little venous bleeding, probably the superficial, a superficial vein. And let's just look at our x-ray for a moment. 2, 3, 4, 5, 5, 6, 6, 7. So why are we not lining up nicely at 6, 7? 2, look, 4, 5 looks pretty good. 5, 6 looks okay, but 6, 7 looks like we're off there. So at some point we'll have to make an adjustment. Yeah, a little bit of wag, exactly. And maybe some scoliosis in the spine, or it could just be parallax that we're dealing with, but it's probably some scoliosis. So her discs are pretty badly degenerated, at least, in my estimation, 60% loss of height. You can look at the discs above, the 2, 3, 3, 4, they look pretty good. But then you get to 4, 5, 5, 6, 6, 7, and they're at least 50% of the disc height is collapsed. She has some bone spurs in the back there. Those have been there for a long time. I don't believe they're really contributing much to her symptoms. Her symptoms are more likely due to the inflammation from the annular tear with the interposed nuclear material basically irritating the nerve root. All right. So we are ready. Give me a little pull, and we're going to make our incision. Let's see, is that big enough? Should be big enough. May have to make it a little bit bigger. So this is all done endoscopically. Endoscopic spine surgery is a newer technology. Endoscopic surgery has been done for years on orthopedics and also with general surgery, right? Gallbladders are taken out endoscopically now. There's endoscopic hysterectomies shot. So there's a lot of endoscopic surgery being done in medicine, but endoscopic surgery on the spine is something relatively new, and most surgeons don't know how to do it. Okay, and you guys are pulsing, right? Yeah. All right, let's get an AP. Coker. Take your time. Now we have more time. Earlier my fingers were getting crushed, but now we have a little more time. That's perfect. So you can see that the tip of the dilator at the front of the spine is pretty much lined up with the spinous process. All right, go back to a lateral. Back to a lateral. All right. Let me know when you're there. All right, very good. That's perfect view. So now I need to advance this dilator down through the ALL into the disc. And you want to do that without advancing your guide wire. And so I like to use my fingers just to get it started. Shot. And I kind of roll it and a little bit of pressure. It's just something you have to practice and get used to. Shot. Once you get started and you're getting in there, you can actually take your guide wire out. All right. Do you mind, Dr. Santiago, give me a little inline traction? Just a little inline traction for a few seconds. Let me know when you're ready. With the slight extension. Oh, beautiful. All right. Shot. Quick shot. Okay, now good. Now I'm going to get this guide wire out. Keep giving me that inline. Shot. Shot. This is the part that nobody likes to watch. That's good, Dr. Santiago. They don't like to watch the hammering for some reason. But the truth is, I get asked a lot of questions about that. The hammering helps me control the amount of energy that I'm delivering to the actual dilator. And I'll tell you when, not yet. And shot. Should be getting close. Now I'm bringing the tube down. This is called a tubular retractor. And a tubular retractor is basically what I'm going to do the entire surgery through. It's a tiny tube. So rather than having a big incision like we showed you earlier, let me have a marker. Do you have a marker?
Like a skin marker, or you?
Yeah, sterile marker.
Can I have one, Rizal, please?
It's good to illustrate what the alternative would be. All right, are you ready for a little inline? All right, give it to me. And shot. Yeah, nice. Not yet. Shot. Beautiful. It's advancing beautifully. Shot. You can see the tube going down. Shot. Just need a little bit more. And like I said, the problem, shot, is that this disc is so scarred down from shot chronic inflammation. Just give me a second. Shot. Yeah. Shot. I want to get down to the foramen and start going out the foramen just a little bit. You see that? Ready? Shot. All right, nice. That's about it right there. Shot. That's about all I can do. All right, good. So we need to get this guy out. Without removing my tubular retractor.
Yeah, you wanna put that in there.
Yeah.
That's right.
I just don't want to pull the whole thing out. Shot. 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 All right, so it's not moved. Let's have the mallet.
Yes, sir.
Go ahead and hold that.
Yes, sir.
Let's see if we can get it to shot. Come out. It's overexposed. Shot.
Nope.
Just came off. Keep it nice and squeezed tight.
Yeah.
Shot. Doesn't want to budge. You have our vice grip. So we have a little vice grip that we use to hopefully overcome stubborn metal pieces. Any questions so far?
None currently.
Did a little biopsy of the Raytech.
It's coming, sir.
Huh?
It's coming, sir.
Yeah. You have a wet Raytech? Sometimes wet is a little better.
You wanna try the cooker again? Or no?
No, let's try this. Shot. Well, I can't say that was easy, but we got the job done. And that's how surgery is, folks. It's never, you guys can go out with the fluoro. It's never the same. It's never, you know, unfortunately I don't want to use the word easy, but there are sometimes challenges you encounter, problems that require solutions. And it's not the first time we've had a little stickiness of the dilator to the tube. Okay, you're supposed to be out. Yeah. Come on, Jordan. tell her what she needs to do, so I don't have to stop what I'm doing to direct her. Okay, your job. All right, so can you guys see this pretty good? Sean?
You wanna use the skin mark?
Yes.
Or-
Yeah, I was going to do a skin marker too. It's sterile, right?
Yes, sir. Yes, sir.
Can you guys see what we're doing here? Sean? Hello, McFly. Sean,
Yes.
are you the silent intelligent type today? This is what the normal anterior cervical discectomy infusion incision looks like. And this is what our incision looks like for the laser surgery. So that big incision is going to make a lot of scar tissue, a lot of swelling, a lot of inflammation in the throat. That's going to affect the patient's ability to swallow. I was reading a post one time about a patient who was having a fusion done in the front of her neck, and she's a professional singer. And she was like, what do I do? And I said, you don't do a fusion in the front of your neck because it's going to change your voice forever. You need the laser surgery done, the Duke laser disc repair. So if you're a professional, singer, and you rely on your voice to make a living, I can guarantee you your voice will be different after a fusion surgery, an anterior cervical discectomy fusion, or even an artificial disc surgery, because all that scar tissue around the voice box is definitely going to affect the way the voice box works. And honestly, there's a lot of lawsuits against spine surgeons by singers. Not me. I haven't had one. But there are a lot of litigation cases against spine surgeons that do fusion surgeries and the patient's voice changes and they're a professional singer and they're not happy about it. And so if you do an ACDF on a patient, you've got to explain to them their voice will definitely be different. Okay. All right, so here we are. We're at the back of the disc. There's some bone spurs and some disc material. And we're going to work our way down to the herniation. We're pretty much near it. Those are the end plates, left and right. This is so scarred up, just as I told you. There's a piece of herniation right there. You see it? It's smooth. Shouldn't be smooth. The only reason a herniation is smooth is because it's been worked on like a stone in the river, by basically chronic inflammation. There's no river in here that normally exists. I've created a small river. But these herniated fragments normally are fuzzy and they're not smooth. The only way they get smooth is from chronic inflammation working on them. So this patient's had chronic inflammation inside the disc, and it started at the annular tear in the back and has worked its way to the center of the disc, and that's what we're seeing is all the inflammation, the effects of inflammation, which is scar tissue basically, and bone spurs, depending on where you are. But anyone that's had an infection or anything that's lingered with lots of inflammation for a long time, you all know what I'm talking about. That inflammation eventually causes dense scar tissue. Dense scar tissue. Surgeons know about this. All surgeons know about scar tissue from chronic inflammation. All right, so just so you know, right here at 12 o'clock is the end plate. That's the surface of the bone. That's part of the disc. Right where I'm working is where the herniation is. That is the herniation I'm zapping away at. And you can see it's not coming out easy. It's stuck down. That's because of the scar tissue we've been talking about. Okay? The scar tissue from chronic years and years of inflammation makes the jelly part stick together, and it's like this, I don't know, earwax is the wrong thing to say, but it's like super hard and it's pushing on the nerves and it's just creating inflammation.
We have a couple questions.
I don't know what the right consistency would be that people could relate to. But yeah, I think if you had, I think earwax is not so bad. I've never called it that before, but the truth is, if you don't clean your ears regularly, and you get this hard, waxy stuff built up in your ear, and it comes out with a doctor, scrapes it out, that's kind of like what we're dealing with here in terms of consistency. Of course, this stuff we're dealing with is not earwax, of course, because we're inside the disc. Has nothing to do with the ear itself, but it's just the consistency of this stuff is super firm and kind of waxy-ish. All right, yes, what's the question?
One of our viewers is wondering, can this surgery be done to avoid a fusion at the same levels?
You need to raise your volume. We cannot hear you in this operating room.
Is this a bit better?
Yeah.
So our viewer is wondering, can this surgery be done to avoid a fusion at these same levels?
Yes, that's correct. So the viewer from YouTube, Facebook, Periscope?
YouTube.
Our viewer from YouTube is asking, hey, can you do this surgery instead of a fusion to avoid a fusion? The answer is 100% yes. So why are fusions done? Fusions are done because somebody has a herniated disc or bone spur and disc that is pressing on the nerves in their neck or pressing on their spinal cord in their neck, okay? Or they have just severe pain, like headaches and neck pain from the herniated disc. So the part of the disc that's causing all the symptoms is the part I'm taking out right now. It's in the back of the disc. It's not the front of the disc. It's not the middle of the disc. It's not the side of the disc. It's literally just the back of the disc. So for years, for the last 60 years, spine surgeons have been taking out the whole disc in order to get to the part in the back and fix it. And then when you take the whole disc out, you've got to fuse it. Otherwise, it'll be bone on bone, slipping around, causing lots of pain and suffering. So the Koreans were the first to realize, hey, well, actually, I realized it a long time ago, but I didn't know how to fix it. Hey, why are we taking the whole disc out in order to fix a little piece in the back? That's a problem. And I just didn't have a solution until about 16 years ago. I met with a South Korean surgeon, Dr. Seng-Ho Lee, from Woodydall Hospital, and he taught me this endoscopic technique of leaving the rest of the disc alone. Leaving the front of the disc, the sides of the disc, the middle of the disc alone, and just going to the back and using an endoscope to see it and fix it. But they were only fixing herniated discs that were pushing on nerves. And when I started to do the procedure for herniated discs that were pushing on nerves, I noticed there was a part of the back of the disc that was torn. And if I spent some time repairing that tear or debriding it, that the patient's neck pain would go away. And so I learned from the basic technique that I learned from the Koreans and a German surgeon who also helped me on the cervical spine, that is. I learned that I could eliminate neck pain and headaches from the neck when I started to look at my patients' outcomes and realized every time I saw them back in clinic that they were very happy their neck pain was gone and their arm symptoms were gone and their headaches were gone. And I realized this is a very consistent finding. But surgeons don't do disc surgery for neck pain. They don't do disc surgery usually for headaches. They only do it for pressure on the spinal cord or pressure on the nerves. And so this was kind of a new thing that nobody had ever done. So surgeons do spinal fusions in the neck to treat pinched nerves going into your arm and to treat a pinched spinal cord. So we call that radiculopathy and myelopathy. They don't do surgery usually for neck pain. But the fusions you're referring to are done for pinched nerves and pinched spinal cord. So the answer is yes, this surgery will replace fusions in the future. But surgeons have to learn how to do it first. And it's not easy to learn this surgery because you need a teacher, someone who can train you. I had to go to another country to learn because there was nobody in the United States doing it. And when I learned the basic technique, I modified it, made it better, more effective at treating neck pain, and I made it so that you could treat bulging discs, not just herniated discs, but bulging discs are small herniations that are causing neck pain, and degenerated discs like this one. Okay? So we're able to treat degenerated discs, bulging discs, herniated discs, anything that's wrong with the disc that causes symptoms in a patient. We're able to treat all that, okay, with this laser surgery. We're going from one foramen on one side across to the other. That's the foramen right there. There's a little herniation in the foramen, and we're going across the middle of the cervical disc, and now we're going out to the other side, right over here. Okay? That's the uncovertebral joint. Right there, uncovertebral joint. And I've already gotten a few fragments of disc out. Now, it's not impressive in terms of the amount of herniations, because the herniations have been dissolved basically through the process of inflammation. All right? I didn't do that. There's a bone spur. People wonder, can you get rid of bone spurs with a laser? Well, we just did. Okay? I don't see anything else in the foramen. It looks clean. Pretty much done here at this level and ready to move on to the next. All right? So you can see the sloping right there of the uncovertebral joint, right where the laser is. If you just look at that end plate, it's starting to slope up like a smiley face. I may try to get just a little more lateral there. By the way, if you're astute and you've been paying attention carefully, you'll notice there's actually movement now of the bones where there wasn't movement before. Do you see that? So we created movement. Fusion surgeries take away movement. We've just created movement with this laser surgery. And I've been seeing that for years and years and years of doing these surgeries. We actually improve the movement. So all other spine surgeries take away movement through fusion, but the Duke laser disc repair is the only one that improves movement. Now, artificial disc surgery, they say it does, but most of the time those discs just fuse. So it doesn't work that well at preserving. They talk about preserving movement. The Duke laser disc repair, we actually create movement. Now, that's what I've observed in the operating room endoscopically at the level of the disc. But I've never had a patient do flexion extension x-rays afterwards to see is the movement really, is it improved on x-rays. But we definitely see it's improved compared to when we started. All right, so now I have to be able to go down and up. Where do you want this?
Yeah, it's better this way.
Yeah, all right. We're gonna move the laser endoscope. All right, so we're finished with one disc, and now I need to go to the next two. So we need a lateral fluoro shot, and we're going to go back and forth between AP and lateral, guys, okay? This is a little tight. I don't know, you may want to take the laser out of there just to preserve it. I would do that, just to be safe.
Yes, sir.
Can you do that? All right, so I think I answered the question. There are 200,000 anterior cervical discectomy infusions done every year in the United States. There's probably 5 times that amount that need it. So we're looking at 1 million cervical fusions that need to be done every year in the United States. At least 900,000 of those, 90% of them, we could do this laser surgery instead, and it would achieve the goals of getting rid of the radiculopathy, getting rid of myelopathy, getting rid of neck pain, and getting rid of the headaches and arm pain that a fusion well done would do. And actually better than fusion, because we don't have complications, at least we haven't to date. I've done about 1,200 of these procedures in 15 years, and we've had 0 complications to date. Now, of course, that's in large part due to my technique, but also it's a very safe surgery if it's done properly. You have to follow a few rules. Okay, are we ready?
We have another question.
Sure.
A viewer on Facebook is wondering, why does it seem like Florida is the new home of all the pioneering techniques in medicine?
Why does it seem like Florida is the home of all new pioneering techniques in medicine? Honestly, I can't answer that for you because I don't know much about other pioneering techniques. I'm just a spine guy, and I don't really know a lot about other stuff going on. I'm very narrow vision in what I do, you know. So, but I can tell you why I'm in Florida, because of my wife. That's my excuse. Well, I came here originally from California because the training that I wanted to get, I wanted it to be the very best neurosurgery training. At the time, I thought I was going to take out brain tumors out of kids, a pediatric neurosurgeon. So I came and I did a neurosurgery residency for 7 years. And then I ended up falling in love with spine surgery while I was doing my residency. And of course, I met my wife, and she's from Florida, so we stayed here. But originally, I'm from the West Coast, California. So that's my story. I can't really answer why other doctors that pioneer are in Florida. It's nice weather. There's no state income tax. Are you guys ready? I don't like that tube there. Okay, let's get one more shot. Now, I'm going to have to move from the disc that I'm in, which is C5-6, down to C6-7. So before I do anything, I want my staff to get that C6-7 disc looking beautiful. We still have a little bit of contrast here. Keep going, guys. Wag it out and figure it out where it is. So the reason why we're not able to see C6-7 as clearly is because there's a little scoliosis, and now of course it's overexposed. It's too bright. So we need to work on that a little bit. Maybe I don't know if the table needs to go up or, huh? No, I think we just got too much shoulder. There we go. So now try to wag it and get it in place. It's not horrible. We're probably about 3 degrees off. So at this point, we need to look at C6-7, the disc below, and I need to see it nicely on the lateral view. Otherwise, you can be tricked, because if you're not looking on the side perfectly, we're still overexposed, guys. I wouldn't go any further south with the base. Try to wag it and find the perfect trajectory. You guys need my help or what? You have another question?
Yes, we do.
Okay.
We have a viewer from Facebook wondering, how long is this patient going to be out of work, and when can they return to normal daily life?
Yeah, great. So you can see the incision. We're going to try to do everything with a tiny incision. So the healing from the incision is basically overnight. And the patient can go back to work the next day if they want to. So lots of patients go back to work the next day, but they just can't lift anything heavy. You got to keep your lifting light, under 25 pounds. So if you've got a desk job, you can go back to the desk job the next day. All right, let's see what's going on here. Let me have control of the wag, please. Bring the base south. South. Stop. Shot. Does that look better? It's hard to tell. Did someone turn the monitor? Because it looks like it's turned more that way instead of towards me. Is that possible? It is possible. Turn it a little more. Yeah, somebody must have been playing around. All right. Let's do a little more wagulation. Shot. I'm going to catch more shoulder there. That looks worse. Don't you agree? All right, so let's go back here, shot. And bring the base south. And shot. And shot. And shot. I don't know, what do you think, Santiago? You think that's better? We're going to need a little shoulder pull. So, yeah. Let's lock it there for now. And let's get a little shoulder pull, just a little gentle. And let's see what we can see. Shot. Shot. Come south a little bit, please. You're too far north. Just a little bit. Half an inch. And shot. All right, well, that's probably going to be the best we're going to get for right now. Okie dokie, you guys ready? So I'm going to come out of this disc with the dilator, and I'm going to move it south. You can actually feel coming out. Shot, I'm out. So now I'm going to march my way down to the next disc, okay? I want to make sure I stay in the midline, so I'm going to ask my staff to do some AP views. Let me just move a little bit more. Shot, all right. Let's go with an AP next, an AP view. I want to keep the tip of this on the bone. This is going to be the hardest part for surgeons, right here, right now. And the patient has to be completely relaxed. You need the anesthesiologist to make sure that the pharyngeal muscles don't tighten up. Okay, you guys overshot it a little bit, but it's still not bad. Shot. All right, good. Let's go with a lateral view. Are we giving a little shoulder pull? So I can feel I'm right on the ALL, anterior longitudinal ligament. It feels slippery to me. Just, no, I got to get my hand in here. Just can't take over that. I can feel I'm on the ALL. Shot. So now I need to just move down a little bit further. Shot. Let's get an AP. I want to see where I'm at. Coker. As long as you stay on the ALL, you're fine. It's a quick shot. Perfect. It's lateral. So we're in the middle still. I'm almost at the front of the disc. It slipped. Okay. Just slipped out of position a little bit. Shot. We're going to have to get back to where we were. Right there. Shot. That feels like the disc. It's good. Now I need to just verify on the AP view. So lateral looks good. Give me an AP view, please. I had it, and then I was a little too ginger with my... That's perfect. Let's go lateral, please. So you got to use a series of AP and lateral x-ray views. You've got to feel the tip of your dilator. I need a mallet. You giving me inline?
Yes, I am.
Shot. That's it? Right there? Perfect. Shot. I feel it going in. Let's get one more AP just to verify. Coker. And then I'll need inline again in a moment, but not yet, Dr. Santiago. You can relax. Just relax for a minute. You have another question?
Yes, a viewer from Facebook is wondering, will this
Lateral.
surgery be a forever fix, or will
Yes.
she need further care?
Yeah, the Duke laser disc repairs you're watching, folks, these things are one and done unless you do something to re-injure your disc before it's healed. So the disc will be completely healed in 1 year. 1 year after surgery. When you make it to a year, you're done. The disc is completely healed. It's about 85% of its normal strength from when you were 18 years old. Okay? So that's as good as it gets. It can't get better. Long story short, if you do something in the first like 3 months to 6 months, something you're not supposed to do, shot, you will re-herniate. You can re-herniate the disc or re-injure it. So you can have another herniation. And that's happened. I have about 1% of the patients, shot, 1 in 100, are re-herniate. So that's out of my control, obviously, shot. And what I'm trying to do is clear the schmutz out of the tube so I can get a discogram here. So But definitely, I've had one out of every 100, 1% will do something to reherniate before the disc is healed. It's usually in the first 3 to 6 months after surgery. Shot? So I think if you make it past 6 months, you're fine. I need the pipe cleaner. If you make it past 6 months, you're fine. But as long as you take it easy, you don't lift anything heavy, you can go back to work. You really got to be careful, because what happens is people feel like, oh my gosh, the pain's gone. Shot? I feel wonderful. I'm healed. But they're not healed. Their symptoms are gone, but they're not healed. That's the problem. Shot? And the disc is still soft, and the area that we repaired is not firmed up yet. It has not healed yet. And so we put people in a collar or a brace. We give them restrictions. We have them follow up with the therapist just so they can keep hearing it over and over again. We even created a Duke Spine wristband. I just cannot get this out. It's just so damn scarred up in the disc. You know?
We have another question.
Yeah, I'll take it in just a second. I think I got a little shot. Now, they could see a faint amount, but it's not really impressive. All right, it's just so much scar tissue in there. No, I have to finish advancing it. Give me a second and I'll take the question. I just want to focus for a minute on what I'm doing. There are certain times when I really do have to focus quite a bit. All right, you ready, Dr. S? I feel it advancing. Shot. And I want to get this to the back where the foramen is. Shot. Which we're pretty close. Shot. You never want to go really into the spinal canal. All right, just to show you all, this is what the whole surgery is being done through. Can you see this, Sean?
Yes, we can.
4 millimeter tube. It's actually about 3.8 millimeter outside diameter. It's all FDA approved. Everything we do is FDA approved. We don't use non-FDA approved things. That's how you go to jail, which I'm not interested in visiting. So people ask us that a lot. Is everything FDA approved? 100%. Yeah, everything we use is FDA approved. Shot? And we wouldn't be using it if it wasn't. Shot? Shot? Our goal is to put Duke Spine Institutes in every major city around the country and around the world eventually. Unfortunately, it takes a lot of money to do that, money I don't have. So, Shot, eventually we'll be there, in case you're wondering, but just not there yet. Shot? Okie dokie, that looks really good, and I feel good about that. So we're going to try to get this. See, it came out easy that time. All right, so one disc down, next disc is C6-7. That's the bottom one, right? We're doing 3 in a row. And you can see C2, 3, 4, 5, 6, 7. So we're at 6-7 now. What's the question you have?
A viewer wonders, if I've had 2 fusions in the past in the neck, would this surgery fix any remaining pain that I'm having?
Yeah, great question. So one of our viewers said, I've had 2 fusions in the past. Could this surgery fix the remaining pain I'm having? The answer is yes. However, I would need more information. Here's why. Was your fusion a cervical fusion or lumbar or thoracic? And do you have adjacent disc disease, adjacent segment disease? So, assuming your fusion was a solid fusion, the surgeon did a good job, the bones are fused together, they're not causing any symptoms, then your symptoms must be coming from above or below your fusion. I don't know which one it is. I'd have to do an exam and look at you. Basically, you'd have to feel that pain, and you'd put your finger on it, mark it, and then you can look at your incision and figure out, usually, is it above or below the incision? Is it at the top of the incision, bottom of the incision? Sometimes the pain is right where the incision is to the sides. That's usually muscular pain. So I would just need to do a little more investigating, but let's assume for one moment that your pain is coming from a disc above or below your fusion. Could the laser surgery be done to fix that? 100% yes. We've done it many times. The only issues I'd worry about if it was in the neck is how much scar tissue there is. Because if you have a lot of scar tissue and you got a thick neck, that's going to make it too risky to do the surgery. Like I said earlier, we've had 0 complications. We want to keep it that way, but that also means that we're selective on which patients we do. Because if you're at high risk for having a complication like a vascular injury, a neurological injury, whatever, I'm not going to do the surgery. So remember earlier I told you that this surgery you're watching, the Duke laser disc repair, will replace 90% or 900,000 of the fusions. That's because it won't replace 100%. There are some people that don't have the right anatomy to do the surgery. In other words, their neck is too thick, for example, or too scarred up from prior surgery. So I just need to see, you know, there's a piece of herniation. Oh, you want me to grab?
No, whatever you want.
No, I know what you want. Great question. So to answer it, most likely we can help you with the laser surgery to fix the adjacent segment disease you have. But let me tell you something. No matter what you have, we can fix it for you. It may not be with the laser surgery. A lot of people don't know that I've done over 1,000 lumbar fusions. I've done over 1,000 anterior cervical discectomy infusions in my career of 25 years. And I've done about 500 posterior cervical laminectomy infusions. So as far as being able to do more traditional surgeries that everybody else does, I do them. I do them very well, better than anyone else, to be honest with you. We do them all outpatient, meaning you get to go home within a few hours. There's no one else in the world that can do that. So we do traditional fusions, we do artificial disc, we do whatever it is that's best for the patient. And 90% of the time, it's the laser surgery. 10% of the time, we can't do the laser surgery. So it's just a matter of figuring it out on an individual basis for each patient, okay? All right, so just to orient you, the laser fiber is the glass thing at 12 o'clock, and on the left at 9 o'clock is an end plate. On the right is an end plate. That would be the end plate of C6 on the left, C7 on the right. So toes to the right, head to the left, and that's a bone spur right there. I just zapped away right there, the golden color. People wonder, does the laser get rid of bone spurs? 100% yes, it can. Now, does that mean I'm getting rid of all the bone spurs? Absolutely not. Why? Because most bone spurs don't need to be removed. They're not causing problems. That may come as a surprise to most people. Everybody thinks, oh, I got a bone spur, that's what I need to have taken out. No, that's not necessarily the case. There's lots of bone spurs in your body that are asymptomatic. We don't take out asymptomatic bone spurs. Asymptomatic means not causing a problem. You understand? We only go for the stuff that causes problems and pain and suffering. How do I know which ones do and don't? 25 years of experience in spine, being one of the best in the world. You learn very quickly if you're really good at what you do, okay? How does Lewis Hamilton know when to hit the brakes in his Formula One car, right? Years of experience. Now look at that down there. That's pretty cool. See those white fibers? You know what that is? Posterior longitudinal ligament. Dr. Santiago, you're an A student in my class. I'm learning from you. Yeah, you are. You are. And he's an anesthesiologist and interventionalist, interventional pain management. Dr. Santiago trained here as one of our, Dr. Patel's fellows. I should say one of our fellows because I guess I've trained him a little bit too. And he has graciously agreed to come and help us today. Our regular anesthesiologist is wonderful, but she was unavailable yesterday and today due to medical reasons, which I can't go into obviously, but she'll be back eventually. But Dr. Santiago is like the knight in shining armor. He came and saved the day. I'm sorry, everybody else, but I have to give him the credit today. We wouldn't be here without him coming and helping. Luis is smirking. He is a knight in shining armor. He's Sir Lancelot.
Of course. I agree.
Yeah. All right. Yes, he is. He's wonderful. So our patient came from out of state, and she wanted to be fixed. She took time out of her life, and her friends and family and everybody. She got ready for the surgery, and she's here. And it would be horrible if we weren't able to accommodate her, because our anesthesiologist was not well. So I'm very, very pleased with the situation. It's worked out for her. This is all just scarred up herniated disc, really bad. And a little bit of scar tissue right here, right over the spinal cord. What I'm most interested in is there a herniated disc in there. So you don't know that unless you peel some of it away. This is all junk in the foramen, pushing on the nerve root. That's the arm that bothers her. So I need to try to get rid of some of that stuff, which I have. Oh. You see, the laser is the most accurate and precise tool you can use. Okay? The laser peels away literally 0.5 millimeter of tissue at a time. And there's the herniation I was talking about. It even has a slight blue tinge to it, doesn't it? You see that? That's because it's nuclear material. The only thing that stains blue is nucleus pulposus. Nothing else stains blue. So if it has a blue coloration, it has to be nucleus. There's bone spurs in that foramen. You see I'm blasted them all the way. You guys see that? Pretty impressive. I'm going to come back the other way because there's still some herniation towards the middle. And I don't want this stuff falling in after we leave and pushing on her spinal cord. Her spinal cord is literally just millimeters away. And look at the movement we're getting. I'm not talking about the tube, but look at the bones, how they're moving. Okay? This surgery, the Duke laser disc repair, gives back movement. I can say that with confidence because I have hundreds and hundreds of video recordings, and you can see on every one of them, the movement in the back of the disc is improved at the end of the surgery. That's because I've released all the scar tissue back here from chronic inflammation. So the herniated disc is broad-based. It goes from side to side. And it's created inflammation over the years that has caused severe scar tissue, and that scar tissue has basically locked the vertebrae in position. So they can't move much, very little movement. And now I've removed all that scar tissue with the laser and the herniation. So I've gotten rid of the source of the inflammation, and I've gotten rid of the source of the spondylosis, or lack of movement, I should say, of this vertebrae with this procedure. This is a revolutionary procedure, folks. And again, I'm the only surgeon in the United States doing this in the cervical spine. I've tried to get other surgeons taught. The problem is that they have a lack of understanding of the significance of this condition, of the disease, and how it affects people, and they don't have the training to do the procedure. And it takes time to learn, you know, and they don't want to give up their practices to learn. They don't want to take a year or 6 months, whatever it takes, depending on our volume, to do the procedure and learn it. So unfortunately, as long as things remain the same as they are now, there's not going to be a lot of surgeons around the world that know how to do this. It'd be like learning how to do brain surgery without actually training to do brain surgery. This is a neurosurgical procedure. I am a brain surgeon. This is one of my procedures. And so you can't do neurosurgery, you can't clip an aneurysm without actually training with someone who does it all the time. You know what I mean? What's wrong?
No, I just pinching this.
You call me pinche? You like that? So it's no different. I mean, aneurysm surgery is extremely delicate. It takes tremendous amount of knowledge and understanding of the anatomy and pathoanatomy and pathophysiology, and that's the same thing here. What I'm doing, endoscopic spine surgery. It requires intensive training, and it's not part of the neurosurgical training because nobody else knows how to do it. So until I start teaching this technique at universities and med schools, which I'm not going to anytime soon because I'm busy taking care of patients right now, I don't have time to go to universities and teach. So they need to come here and learn. We have fellowships, but until they actually start coming here and learning, there aren't going to be a lot of surgeons that know how to do this, unfortunately. All right, so I'm looking at this area. It looks pretty good. There's still a little bit of scar tissue, but remember, I'm not here to get rid of the scar tissue. I'm here to get rid of her arm symptoms. Look at that beautiful clarity there. That's the foramen. I may want to take a little more of the scar tissue out, just because it could be compressing the nerve root. How are we doing on irrigation? Yeah. I'm just about done at this level here. We need another 3 minutes and we're done. It's beautiful. Look at that air bubble there. Pretty cool, huh? So it's nice. We don't have much bleeding. We're getting a little bit now, but for the most part, we've had great visibility for you all to watch. This is the other foramen on her right side. Now, she didn't have symptoms over here, so I'm not going to get too carried away, but there's definitely some herniation there. Okay, we're done at C6-7. So now I just got to, why is my irrigation so sluggish? I've just got to get us over, scope off.
Lights on, please.
So I just got to get us out and over to C4-5, the last disc we'll be fixing. And then we'll be done. All right, let's get everything ready. Let's get the laser out, laser fiber out. So far, we've lost probably maybe 2 cc's or 2 milliliters of blood, probably 40 drops. What is it, 20 drops per cc?
Right.
Yeah. So 20 drops of blood per cc. We've lost about 40 drops of blood at most. So you're talking about 2 milliliters of blood loss. There are surgeons who do open surgery here, ACDF, they lose 500 cc's, typically. So there's a lot less blood loss with the Duke laser disc repair. Can you check my mask? It feels like it's sliding.
Yeah, it kind of is.
Pull it up a little higher. Is that good?
Yeah, that's better.
So Duke laser disc repair, smallest incision, 4 millimeters. Least amount of scar tissue from any surgery on the spine. Least amount of blood loss, 2 or 3 cc's of blood, nothing. Fastest recovery, fastest return to work, lowest number of complications. We've had 1,200 surgeries done over 15 years, 0 complications. Highest success rate, getting rid of neck pain, 98% is our average. So when patients come to us with neck pain and they've been determined to be a candidate for Duke laser disc repair and we do their treatment, 98% elimination of neck pain is our average. 98%. There's no surgery in the world that comes close. Of course, it's outpatient, so you don't even go to the hospital. There's absolutely no disadvantage to this procedure except you can't get it done near your house. You have to travel. That's really the only disadvantage. And you're going to have to fight your insurance company most of the time to get them to pay for it. They don't like paying for new technologies that people like. Shot? But we'll help you with that fight. We have good lawyers, and they specialize in suing insurance companies and making them pay for what they're supposed to pay for. So, don't be discouraged. Have hope. Duke Spine Institute offers free MRI reviews. We don't even charge you to look at your MRI, see if you're a candidate for treatment, whatever the treatment is. Okay, so we've done 5, 6, 6, 7. Now I've got that last disc up there to get to and fix. So here we go. Are we ready, everybody?
We are ready.
All right, I'm going to come out again, and I'm going to go up top. Just give me a few minutes to get this done, and then we can talk some more. So once again, pop out, shot. Yep. Now I need to know where I'm at, which side. So give me an AP quickly, because we're off to the side. So I got to correct. Shot. I'm actually close to the middle, which is good. Shot, shot. All right, let's go back to a lateral. Damn. Not bad. Not bad at all. Let me know when you're ready. All right, yeah, I'm inside the disc, that's why. So, that was actually pretty accurate there, huh? I got lucky. All right, shot. Now we're moving up to the next one. I want to make sure I stay in the midline. Shot. Okay, I can feel the bone spur in the front. Let's get another AP to make sure I haven't deviated left or right. You want to make sure you're in the middle. You want to be over the ALL, anterior longitudinal ligament, between the two longest colon muscle bellies. That's the ideal position. There's a little trough there that kind of keeps you in there. All right, that felt pretty good. Shot. That should be middle, up. Yep, lateral, go. So I moved like back to the middle, then I went up to the 4-5. Not as up as I want it to be. Are we wagged properly there, guys?
Yeah.
Maybe I slid down. Huh?
I didn't change it. Do you want me
No, but you got to change it because we were at 6-7, which was off wag because scoliosis. Now we got to get back in. I just want to make sure I do that before I go any further. Shot. I think that's pretty good right there. Yeah, I could live with that. All right. All right, shot. Lateral. I mean AP. That looks really good right there. Just got to keep it from sliding. Make sure I'm in the middle. Quick shot. That looks perfect. Lateral. So I am right at 4-5. We're ready, doctor? Do not try this at home. All right. Shot. AP. Again, just stay where you are. Give me an AP quick. I want to make sure as I go, before I go any further, that I haven't gone off to the side, because it would be catastrophic. That looks good. Give me a nice clean AP. Give me your best. Get those spinous processes lined up. Center the fluoro towards you. You guys are too far to me. All right, that looks perfect. Look at that, right on top of the spinous process. All right, lateral. So you always want to check your fluoro pictures to navigate. Just need you for another 30 seconds. Dr. Santiago, give it to me. Yep. Shot, you can actually feel it sliding in. It kind of grabs the dilator, takes it where it wants it to go. All right, so still tight. Give me a pipe cleaner. I want to do a discogram. You can rest, Dr. S. So, been talking to some people about expansion. I would love for you to be part of it. think you'd be happy with the arrangement, Sean. Felt some go in there. There we go. Look at the tear in the back of the disc. That's finally nice. So look at the dye, the black stuff, underneath the tip of the dilator sitting in the middle of the C45. Look at the dye going out through the tear. That's called the annular tear. That's what we're here to fix. And it's going out the back where the nerve root is. I need to get this in further. So, all right, nice traction for just a little bit longer. Shot. Almost there. Shot. Yep, perfect. Now let's get this in. Again, for those of you that joined late, the whole surgery, can you see this, Sean?
Yes, we can.
The entire surgery is done through this tiny little tubular retractor. It's called tubular because it's a tube. It's a retractor because it pushes the tissues away and creates a space for me to work in. People think this is percutaneous. It's not. Percutaneous means done with a needle through the skin. This is not a needle. The needle was earlier. Shot. But this is a true endoscopic surgery, very far from being percutaneous. Are we okay over there? All right, so I'm just about done. I need a little bit more help, and we're ready. Just got to advance. Shot. Again, you want to make sure your dilator is not going forward. Give me some good traction. Shot. Almost done. Shot. Okay. Shot. Give me some good traction and extension, or just actually neutral. Shot. Beautiful. Almost done. I think that looks good. Let me just look at it for a second. Maybe a slight bit more, if I can get it. We are really biopsying the heck out of that, huh?
Yeah.
Shot. That's because she's so collapsed. And that's good. And more important than the collapse is her disc. Okay, so this is the bone. This is the bone. There's a cushion between it, right? Normally that cushion is the disc. It's fluffy and cushiony, so that when you move your neck around, you move the bones, it's got a cushion between the bones. You see that, Sean? So in her
Yes.
case, the disc has been damaged, and all the scar tissue has caused it to collapse and basically turn into tough scar tissue, just holding the bones so they don't move very much, but when they do move, it's painful. And that's what she's got. So I had to spread those guys back apart with this tubular retractor, which is very hard to do, and it's limited. I can't do it completely. I can't do it as much as I want to because the bones are stuck down together until I start releasing some of the scar tissue. Let's just see if we can pull it out. I'll hold the tube. Go ahead. Twist it. Twist and shout. No, I was talking to my son the other day, and he told me I had him and my daughter watch this movie called Ferris Bueller's Day Off. You guys remember that? Great movie. Shot? Anyway, let me have the vice grip. He told me, Dad, I watched it 3 times now. I said, that's awesome. 3 times. Yeah, I guess I better take the towel. Uh-huh. Who else uses a vice grip in surgery? Not many people. Not many people. We use hammers, we use vice grips. We do whatever it takes. Orthopedic / spine / neurosurgery. You know,
Do it all.
it takes elbow grease, it takes ingenuity sometimes. You never thought a neurosurgeon that does delicate surgeries would use a vice grip, did you? No. Nope, nope, nope. But sometimes we need to.
Skull ball, please.
When the going gets tough, the tough get going. Isn't that what they say? Huh, Sean?
Yes, that is what they say.
Okay, so for those of you watching and you want to learn more, I recommend downloading the Duke Spine Institute app. And everybody misspells Duke. It's spelled D-E-U-K, not D-U-K-E. D-E-U-K, Spine Institute app. It's on the Android and platform as well as the Apple iOS platform. It's free. And there's lots of useful information about neck pain, back pain, thoracic pain, treatments, cures, diagnoses, lots of good information. Plus you can watch live surgeries through there. The other thing is we have a Facebook support group. For those of you who like Facebook, it's called Spine Surgery Support Group. And we pretty much let anybody in there except for people who break the rules and try to like advertise weird stuff. But you can go to the Spine Surgery Support Group. You don't have to have surgery to join. It's for anybody that wants to learn more about spine, whether they have surgery or not. And it's a great community. It's been growing over the last year. I think we have over 500 members. So invite your friends to join. We pretty much accept everybody that wants to learn and participate. What I found is a lot of the support groups have trolls that for some reason they don't want people to learn the truth about being cured. And I will go into some of these Facebook groups, for example, and start talking about there are people who are suffering with chronic pain. And they're like, I'm in so much pain, I don't know what to do. Should I do marijuana? Should I, do other crazy narcotics? And I'm like, no, get fixed. Then you don't need any of that stuff. And they were like, well, you can't fix pain. Yes, you can. Who told you that? So as soon as I tell people they can get their pain cured from their back or their neck or their thoracic, the trolls start coming. And they start saying, don't lie to people, you can't cure pain. We do it all the time. Done it thousands of times at Duke Spine Institute. So the truth is that you really can't cure pain most places. Most places you go for your back or neck pain, you can't cure. They can't cure it. But at Duke Spine, we can. You just have to invest your time and effort into getting it done, and we'll do it. There's a piece of herniation, by the way, coming out. It was wedged in there, and I just cut it in half, and the actual laser itself does cause a pressure wave. Oh, by the way, as I try to move the tube, I can't get any movement out of the bones, you see? So watch what's going to happen when I'm done. There'll be some movement. It won't be much. It'll be a few degrees. It certainly won't be normal. It won't be the normal movement that this patient had when they were younger before they injured their disc. But there will definitely be movement, as there always is. There's a herniation there I'm going to have to work on. This is our last level, by the way. This is C45, for those of you wondering. And some of the pieces of herniation just come out with the pulse. This is kind of like a pressure washer, the laser. Not only does it use heat, energy, or use heat to vaporize tissue, but it also creates a pressure wave, like a pulse. It's really powerful. And that pulse blasts things. You'll see them start to move. Now we're at what, 20 watts here? Yeah. 20 watts on our, what is it, a luminous?
Yes, sir.
A luminous laser. Beautiful laser. Oh, there's a herniation just wiggled out. You see that, guys? Oh, I love it. Reverse herniation. Stand by. I'm going to grab it. It actually would look like it danced out of there, didn't it? It looked like it did the samba. What do you think, samba or more of a merengue?
He was definitely dancing, for sure.
Yeah, it was dancing. But I don't think I can get it yet. It's stubborn. It wants to dance a little more. Let's see. All right. No. Oh, it looks like it. There it is, dancing again. It kind of went back into the corner, didn't it? This time I'm just going to dance it right out. Let's go. Come on. Come on now. That's a piece of herniation. I couldn't get it with the grabber, so look at that. Nice, huh? I could try again. I don't know. Let me try one more time with the grabber. If not, I'll just have to cut it up into pieces with the laser and get it out piecemeal. Oh yeah, there's our samba dancer. Beautiful, huh? So why is this technology being kept from everybody? Well, probably the biggest reason, I hate to tell you folks, is your surgeons make more money doing fusion surgeries. So let's be frank and let's have a frank conversation. If your surgeons make a lot of money doing fusion surgery, and the companies that sell the metal screws and rods make billions with fusion surgery, then you've got two groups that are totally against you having this less invasive surgery. It's 100% guarantee your surgeon's going to make less money with this surgery compared to fusions. So we saw the same thing happen with artificial discs. When artificial discs first came out years ago, the surgeons didn't want to do them because they were making less money. I'm sorry to tell you the truth, but it is the truth. And you need to know the truth because you're the patient. And you guys are the consumers, and you're the ones, you don't want to have something done that doesn't need to be done. Let me see if I can get, that would be like, for example, let's say the United States had an argument with China, just hypothetically. And the laser surgery, I could go in and I could talk to China. There it is. And I can negotiate a peace, and we can get what we want. They get what they want. Everyone's happy. That's called a negotiation, right? Nobody gets hurt. There's no violence. There's no cost. It's inexpensive. Now, the fusion surgeries are kind of like going to war with China to settle our differences, right? Normally you'd say we don't want to go to war. You don't want a fusion either. But the problem is the people that are promoting the fusion, the people you trust, your doctors, your implant companies, they all make more money with fusion. So, of course, the people that make the bullets, the rifles, the mortars, the missiles, the ships, the warships, they're all going to make trillions of dollars. This happened in the Gulf War with Halliburton. Look at how many trillions of dollars Halliburton made from the American taxpayers because we went to war in the Gulf. Is that good for America to spend that money to resolve issues in the Middle East? No. What if we could have resolved it with just a face-to-face compromise, like that's what the Duke laser disc repair is. The problem is that the people that are used to making money on spine surgery are not going to be making money, so they don't want this solution. Just like the people that make the Apache helicopters don't want peace, they want war, because that's where they get their money, making tools of war. Oh, look at that herniation right there. That thing is amazing. We're going to get it with the grabber. So I've been fighting these forces that are far bigger, more powerful than me for years, trying to get them to do what's best for patients, but they don't want to. Hey, let me show you guys the herniation. Turn the light on for a second. Sean, look over here. Where's the other one?
We can see it.
Can you see this? I just fished this out. See it? Right there, Sean?
Yes, we can.
Can you zoom in on that so people can see it? Hey, don't touch it. Oh, there's another one. All right, there's another one I took out. So there's a couple of the herniations that I took out. You see the little grabber I have? It's super tiny. Okay, it's not even as big as my nail on my ring finger. But I grabbed that thing and I pulled it out. So the laser frees these things up, and then the grabber grabs them and takes them out. Okay? Pretty cool. But there's no metal, there's no fusion, there's no cages, there's no screws, there's no metal plate, there's no biologics. Okay? This is all natural. And that's the problem for you guys, is that there's not big money makers making money on this, so they're not supporting it. They're against it. I know a neurosurgeon who is the head of the education of neurosurgeons. I won't mention his name. He came to me 7 years ago and said, "This surgery you're doing is amazing. I want all the neurosurgeons to know about it." And I said, "Okay. Hey, what do you want me to do?" He said, "Do a video. Make a video of the surgery, how you do it, and I'll put it online and I'll teach everyone how to do it, all the neurosurgeons." This is after training, after residency training. Okay? So I did the video and I sent it to him. And he called me back a few days later and he said, "Doc Ara," because he knows me by first name, he's a neurosurgeon. He said, I can't publish your video on the Duke laser disc repair." I said, "Why not?" He said, "Because people above me, powerful neurosurgeons that make money being consultants for implant companies that sell the screws and rods, they won't let me put it and teach other neurosurgeons about it because they don't want them to know." I said, "Are you kidding me, dude? I mean, it's been peer reviewed and published. It's science. It's real. It's good medicine." And he said, "I know, but I can't do it. They refuse to let me do it. And they're threatening that they'll fire me from my position if I do it." I mean, shocking, shocking. And that's why I started doing what I do now. It made me really angry that the institution was against the people. I wouldn't want a fusion. If I had a herniated disc or bulging disc in my neck, I want this surgery done. All natural, outpatient, safe, very effective. And to know that the people that I became a member of their society and I became a neurosurgeon because I respected them as being great doctors, great surgeons, to know that they were doing this. And I wouldn't say all neurosurgeons are bad. I just say that there's some in a position of power that are controlling, what's done and blocking new technologies that where they are the companies they represent. You can see who they represent in their disclosures, right? It says consultant for DePuy, consultant for Medtronic, Sophomore Danik. They make literally tens of $millions a year by keeping an eye on things and making sure nothing changes and that the companies keep making their billions of dollars doing fusions. Okay? So why am I telling you? Because you all need to know the truth. What are you going to do about it? You're probably not going to do anything about it. I find most people don't do anything about the truth anyway, except run from it. But there's a few people out there that maybe they want to know the truth and they'll do something about it. I'm trying to do something about it in the limited capacity I can.
We have a couple questions.
Sure.
One of our viewers from Facebook is wondering, this level seems to have a lot more stuff coming out of it. Was this the worst one?
Oh, great question. So one of our viewers said, hey, compared to the other two levels, this one seems to have a lot more stuff coming out. Is this the worst one? The answer is yes. A lot of times you can't tell based on the MRI things look the same, are very similar. You know, if you have 3 disc herniations, they may look similar. Sometimes you could see that one's a lot worse. But the truth is that you never know until you go inside the disc, like we're doing right now, and you can see the structure of the disc. You could see the tissues and what they look like and how they respond to the laser energy. You know, the laser changes them. It molds them and shapes them. And based on their response to the laser, you can kind of get an idea of, you know, how much scar tissue there is, how much bone or calcium there is inside some of these tissues. Like the golden color right there, you see the golden color? That's all calcium. That's with the effect of laser on calcium ions. Basically, calcium is a metal ion, and that's the effect of laser on those metal ions, those calcium ions. So I would say yes, this is definitely the worst of all the levels. Yes. You have other questions?
Yes, we have another viewer that's wondering, same question that we had earlier, sort of. Can you go back and fix someone who has had a fusion and now has adjacent segment disease?
Yes, yes. So the Duke laser disc repair, or just me, I can fix adjacent segment disease. Can it be done with the laser? Most likely it can, but I need to see the MRI and I need to see the patient, like where their pain is coming from. They need to show it to me. We do free telemedicine evals at Duke Spine. If you want a free evaluation, we do Skype, and we want to see your MRI. Just go to our website. Sean will give you a link. You can go to the Duke Spine Institute's website, and you can request a free telemedicine consult where we'll spend 10 to 15 minutes going over your MRI and what we can do to help you get out of pain. It's all free. What more could you ask for? All right, we're almost done here. Probably another 5 minutes. Dr. Santiago, just another 5 minutes, I think. I always say that and then it ends up being longer, but look at the movement we're getting now. It's not a lot of movement, but you can see the movement of the bones, right? You didn't see that earlier, did you? Because it wasn't there. And now we're getting it. It's pretty remarkable. Once again, there is no other spine surgery in the world that gives you back movement. Now, they argue that artificial discs preserve movement. They don't give you back movement. This Duke laser disc repair does give back movement. And I have the videos to prove it. I mean, literally hundreds and hundreds of them. And where we usually see that the most is in the neck, cervical spine. Yeah, that's the most common. You can actually see the bones wiggling, right? All right, we're just about done. I've done pretty much all that I can do. Feel pretty good about it. Maybe I'll look over there one more time and then we'll be done. Great questions, by the way. We got one more surgery left today, and that is another cervical laser, right? A 1 level.
Yes, sir.
So we'll be doing that next. So stay tuned. And then we'll see this patient off. She is from out of state.
Scope off, please. Lights on, please. Thank you.
She traveled here for this surgery. And I saw on her Facebook post the other day that she actually watched a rocket launch. She said she had always wanted to watch a rocket launch. And she watched a rocket launch. It was one of Elon Musk's rockets. He was launching the Skylink satellites. I think Starlink satellite. There were like 30 of them or something in there. So she was very happy, and she was actually in a hotel on the beach, and she could see the launch perfectly. Yeah, so pretty neat. All right. right, so I'm going to show you all what we did here. It's pretty neat. Give me a second. I'm going to take this. Oh, just so you all could see, get the light on here. Let everybody see what we've got. Let me just show them real quick. So the whole surgery is done with this. We call this the endoscopic rig. You see that, Sean? Huh?
Yes, we do.
All right, so let's break it down. We've got the camera here, which attaches to the back of the scope. Okay. And we use a high definition camera. And then you've got the scope itself. You've got irrigation coming on the side here. All right, so that's the irrigation. Go ahead and take that, Luis. And then we got the light source right here. This brings light. You guys see that? Right? Light illumination down to the end. And then you got the scope, which is beautiful. That's it. Now, over here, the whole surgery, 3 discs were fixed with one tiny little cut in the neck, 4 millimeter cut. When this patient's healed up a couple of months from now, she won't even be able to find that cut. It'll be gone, just totally gone. That's the beauty of the surgery. No scar, no difficulty swallowing, no hoarseness or voice change permanently.
Concerned about the swallowing. Since I was reading about it,
Really?
my concern was about trouble swallowing.
So our anesthesiologist, Dr. Santiago, says one of her main concerns was swallowing. Yeah, if you have an open fusion surgery or artificial disc surgery, you're going to have swallowing problems. And I see people with those swallowing problems usually for the rest of their life. All right, let's show the incision. Can you guys see, Sean?
Yes, we can.
All right, you ready? So it's right here. Tiny little incision, 4 millimeters. Go ahead and hold pressure.
Yes, sir.
We lost like 3 mils of blood, 3 milliliters, which is tiny. 60 drops. I don't even think we had that much blood loss, but we'll call it 3 mils. I'm going to come over to the conference room. We'll do a little interview. I'll answer questions, and then we'll be off to the next patient.
All right, everyone, thank you for joining us for the post-op Q&A. We're going to switch over to Dr. Duke's face cam in just a moment here. Go ahead and type up any questions you have remaining for the doctor, and he will answer them. But for now, I'm going to hand the microphone over, and he'll tell you a little bit about the case you just watched.
All right. Well, hello, everybody. I'm Dr. Duke Machen, and thank you, Sean. We just finished a cervical, which means the neck. Cervical spine is the neck part of the spine as opposed to thoracic and lumbar. A cervical Duke laser disc repair. This was a 3-level, meaning 3 discs. They happen to be in a row, C45, C56, C67. And this patient presents with basically pain in her neck going down into her left arm, some headaches, and what we call cervical brachial pain, or pain starting in the neck coming into the shoulder area. She had 3 discs that were degenerated, herniated. There were annular tears at each level. So there were a variety of different, we call it pathology. Pathology means abnormal anatomy, abnormal function of tissue. So she had 3 discs that were pathological, causing symptoms. And she had considered the traditional surgery, which would be a fusion. If you want to take a look at this here. Fusions are done with, can you hold the mic for me? They're basically done with a lot of times cages. Can you all see that cage right there? And there's another one there. Those cages go where the disc used to be. So to put a cage in, you got to clean the whole disc out, put a cage in. Usually there's bone graft inside the cage, so it promotes fusing one bone to the other. Then you got this metal plate right here. Now that plate's sitting on the front of your spine. The problem though is that your esophagus or swallowing tube sits right there normally. And so the plate now is like fighting the esophagus or swallowing tube for the same space where the esophagus used to live. So the plate's basically displaced the swallowing tube out of its home, and the esophagus comes back at the end of the surgery, and it's like, wait a second, why is there a piece of metal here? This is where I live. Who took my home? So that metal is going to be rubbing on the esophagus. You know, that's one of the downsides of fusion surgery is you got metal, esophagus sitting there, and then of course your trachea, which is your breathing pipe, is right in front of that. Your carotid arteries are just on the side here. Your vertebral arteries run through those holes there. So there's a lot of really delicate soft tissue structures in this area of the fusion, and that's why people have trouble after fusion surgeries, because you can have damage during the surgery to these tissues, the esophagus, the trachea, the carotids, the jugular veins, the vertebral arteries, even the nerves and spinal cord sometimes get injured, or the dura. So a lot of potential for complications with these open fusions. The other thing is you get complications from the hardware. Once you put it in, like the cage could move or not fuse, the screws could back out of the plate could be put in wrong to where it's kind of counterlevered off the spine like that. I see a lot of surgeons do that, just bad craftsmanship. Well, guess what happens down here at the pokey part? That's where the esophagus goes down to your stomach, so that starts pushing on your swallowing tube. People have trouble swallowing. So there's a whole lot of problems that come with instrumented fusions where you're putting hardware in. And if you don't use plates to do your fusion, then the chance of fusing the spine goes down dramatically. So there's all kinds of complications with pseudoarthrosis without using instrumentation. So the whole world of spinal fusion is bad. We've moved past that now. Now we're doing basically all natural endoscopic surgery where there's no metal, there's no cages, there's no bone graft, there's no scar tissue afterwards, there's no moving structures around and hurting them. Basically, it's a tiny little 4mm incision, smallest surgical incision in the world. There's nothing smaller except needles, and needles aren't considered surgery. So this is really the smallest incision. And what I'm doing, folks, so you understand, is if we look at this little, what we call the spinal segment, you got vertebrae, herniation, pinched nerve, and what all of us are targeting as spine surgeons is that little herniation in the back of the disc. We all like to go through the front, and when we get there, this is what we see, just this view like this, and that's all we can do. You can't wrap around here and fix this because there's blood vessels and important structures they're blocking. So the surgeon's only way to get there is to actually go through the disc. It's called transdiscal. Now, when you're doing a fusion or an artificial disc, if you don't have an endoscopic surgery like the Duke laser disc repair, which I'm the only one in the United States doing, basically what you have to do is scrape all this red stuff out of here. Scrape it out till you get to the little piece in the back. You're looking through these little bones, this little space right there called the disc space. You're looking through that. Sometimes they use a microscope. I do sometimes as well. It's better to use a microscope if you're doing it open. A lot of surgeons don't have the microscope because it's expensive. It's $200,000 for that thing. So they just end up kind of eyeballing it to the best of their ability down a dark hole. And they're like in there trying to scrape out that thing, and it's really hard to see. All right, so they actually then will scrape it out and they're done, right? No, because now you've got a space between these two bones that's a gap. And you got bone with a space and then another bone. They're just going to collapse on each other. You're going to have all kinds of problems. So to prevent those bones from collapsing because you took the disc out, they got to put a spacer in there. And that's where these little plastic spacers come in, okay? Hopefully you all can see them. They're right there. Can you see that? Yeah. So those spacers keep the bones jacked open, but if you don't fuse the bones together, they're going to start wobbling around on the spacer and they're going to cause horrible pain, bone spurs, pinched nerves, all kinds of problems. So what the surgeon then has to do is they got to fuse. So the whole use of the cage and the fusion is only because the surgeon took the whole disc out to get to the little piece in the back. Well, you saw today with the laser surgery that I was able to get that little piece in the back without taking the whole disc out. I just passed through that disc and I just used the laser to zap away the herniation from the inside out. The Duke laser disc repair is far more successful at eliminating neck pain, headaches that come from neck pain and herniated discs, and arm symptoms than traditional open surgery. So a much better procedure. It's outpatient. Our patient will go home in an hour from now, and literally a Band-Aid incision. Okay? Great surgery. We need to get the word out so people don't have to go through fusions and all the complications that happen from fusion and the bad results that happen from fusion. And artificial discs, in my opinion, are even worse than fusion. So don't talk to me about artificial discs. They pop out frequently. They fuse themselves over time. They don't actually stay mobile. And they don't work anywhere near as good as a fusion does if the fusion is done properly in the cervical spine. But the best of all of them is endoscopic surgery. There's no fusion, no metal, no artificial disc. It's all natural. You keep what God gave you and don't let people take it out. Okay? Any questions?
There are no questions, but we do have a lot of the patient's family in the chat sending their greetings.
All right. Well, it's a pleasure to meet everybody. Give her lots of support when she gets home. Sometimes it takes time to heal up from these surgeries. She'll have a little bit of neck discomfort that she didn't have before the surgery. Her arm will probably end up being numb, and that takes 3 to 6 months to go away. It just takes time for the nerves to heal. But I was very happy with the surgery. It was successful. We only lost probably 2 or 3 cc's or milliliters of blood. That's nothing. And we'll keep her in a collar until things are healed up. 1 year after surgery, she can do whatever she wants. Anything else we need to talk about? All right. We'll see you soon for the next one. The next lady has a bigger neck. I'm a little more concerned about it. I told her there's probably about a 10% chance I won't be able to do her surgery. She's a C6-7. That's the lowest disc. That's the collarbone right there. Always gets in the way in a lot of patients. I'm just worried that I won't be able to get there because of the thickness of the neck, plus the collarbone being in the way. So I'd say there's a 9 out of 10 chance I'll get it done. There's a 1 out of 10 chance we won't get it done. And that's a risk that people have to take when they come here. There's always a small chance we wouldn't be able to do the surgery, okay? Because of anatomy. Have a nice day. Hopefully we'll see you